How are you?
Thank you. Thank you. I'm so glad to be here, to be connected with you. And it's such a great honor for me to see you. I hope I will see you soon in person.
Same for me. I'm very pleased and honored also. It's a privilege to be here with three of my dearest and best co-workers who will talk today together with me. Two are working with me in Genoa and one is in Rome, but she has been my co-workers for many years. So I consider them as my school, my staff.
Sure, we will have an amazing rheumatology session today with you.
Dear Professor Rheumatology, dear Professor Ravelli, sorry, if you let me, I want to just have a brief introduction of all lectures, then I want to pass the session completely to you. Just we have a special guest also here.
Hello. Hello, nice to meet you. So, but let me, Aylar, will you?
Sorry, I'm busy with the other session that is going on in the next hall here, but I came here to thank you in person. You are a great person. You are a great scientist, and this is the real honor for Tehran University of Medical Sciences to have you joining a session. Thank you very much, Professor Ravelli.
Thank you so much. You are extremely kind.
No. The kindness is all yours.
Thank you. It's a pleasure to be here.
Thank you, and have a good session. Bye-bye for now. I will join you at the end of the session. Thank you very much.
See you later then. Thank you so much.
Thank you.
Thanks a lot, dear Dr.
Yes. Tell me, will you run the recording and then we'll have a discussion later on? What you prefer to do?
As you wish. I am completely on your commitments. How do you want me to do? I just want to start. I just wanted to start a little bit introduction of the lectures. Then I pass the session to you. I can share the recording of you and Dr. Consolaro, but I have no recordings from Dr. Silvia Manzoni and Dr. Silvia Rosina.
Okay. So the idea would be to first run Dr. Consolaro, then Dr. Silvia Manzoni, she can speak live, and then Dr. Silvia Rosina, and then myself in the end. If you wish, you can also send the recording to save time. Or
as you wish. No, we can have you live. It would be a great pleasure to have your live lecture.
I can give the lecture live if you wish.
Thanks a lot. So now of you as
Alessandro,
everybody.
if you also Alessandro is here. If you wish, you can give the lecture live, or if you as you prefer.
Dear Professor Alessandro is ready, we can pass. So if you agree, I want to start officially the session with the session clip, and then we can go on.
Okay, good.
But just a second. I think you can give I can give the lesson. We can use the record of my lesson, but I don't think it's a good thing to have this lesson first.
No, because I thought that we should have because the second lecture is on ultrasound, and then it's JDM, and then lupus. I think it's
because I thought I talked about treat to target in JLA.
Yeah,
I didn't talk
target. Then ultrasound.
Okay.
And then juvenile dermatomyositis, and then lupus. So we will cover all main diseases. So JIA should come first, and the ultrasound is assessment. So I think it's okay.
Angelo, please. Sorry. Hello, everybody.
Hello. Nice to meet all of you, and nice to have all of you.
Nice for me for being here, and thank you very much for your kind invitation. I apologize, but I cannot run my slides here, and I send you both by Google Drive, and we transfer my presentation.
I will check up again for sure.
Okay, thank you very much.
You're welcome.
Okay. So just Aylar, tell the audience to send the questions through the chat.
Yes, for sure.
We will answer the questions at the end of all 4 talks.
For sure, yes. So we have the Q&A at the end of the session. Yes.
Okay.
Just let's watch this for first.
So you will.
Thanks a lot for watching. Again, welcome all participants, all audiences, and all dear lecturers to the session of updates in pediatric rheumatology, which is managed by dear Professor Anegllo Ravelli from Italy. And we are pleased to have 4 lectures in the session. Just dear audiences, this session is streaming
Dear Aylar, we lost your voice.
There is something wrong with the connection of Aylar.
Okay, now I'm here. We will go on with 4 particular lectures today, and thanks all of you for accepting our invitation. Thank you so much, dear Professor Ravelli, for arranging this particular session for us. I'm sure that we are going to have an amazing session. As you wished, we will start by Professor Alessandro, yeah?
If you wish, I can introduce briefly the session. And
yeah, please.
Just to say, since I am the facilitator of the session, the moderator, just say that we will cover the three main diseases of rheumatology, juvenile arthritis,
I have my voice now.
Dermatomyositis and lupus, and we will provide you with an update. So the first talk will be given by Professor Alessandro Consolaro on the treat to target strategy in juvenile idiopathic arthritis. Then Dr. Silvia Manzoni will provide you with an update on imaging, particularly ultrasound in juvenile idiopathic arthritis. And Silvia Rosina, who is my co-worker at the Gasini Institute of Genoa, will talk about the assessment in JDN. There have been many novelties in this field recently. And then I will close the session by providing you with some insights into the polymorphisms of systemic lupus erythematosus. So let's start with Alessandro Consolaro, Professor Consolaro, who will provide you with the last advances in the treat to target in juvenile idiopathic arthritis. Please, go ahead. Just remind the audience that the questions can be submitted through the chat, and we will answer the questions at the end of the 4 talks. So please keep...
Again, so I'm sorry for interruption. I think you have my voice. We experienced a technical problem here, dear Professor. Thanks a lot for managing this session. Okay, we are waiting. Dear Dr. Kahramanlu, would you please stop the sharing too? Thanks a lot. Dear Dr. Consolaro is co-host, so he can share the slides.
Now, as agreed upon, please send my presentation that I've sent you.
Yes. Sorry, I'm gonna share it. So just in a minute. I'm so sorry. Do you have anything? Your sound or?
No, not yet. Please share. And now you're
Good evening,
sharing your
everyone.
screen.
Thank you for the
What
kind
about
introduction,
that?
and thanks to
And
the organizing
please
committee
pause it
for
and
inviting me to
please
talk to
stream.
you about.
That's okay.
Good evening, everyone, and thank you for the kind introduction, and thanks to the organizing committee for inviting me to talk to you about the treat to target strategy in pediatric rheumatology. Here is some important literature supporting my talk. I really invite you to read this important manuscript if you still haven't. The treat to target concept dates back to several years ago. It was developed in the 80s for the management of chronic conditions like hypertension, like diabetes. And this concept was transferred to rheumatology and initially to rheumatoid arthritis, because mostly indirect and few direct data in favor of such a concept were available for rheumatoid arthritis. And you will see later that for pediatric rheumatology is now in that condition. So about 15 years ago, a few conditions allowed the implementation of the treat to target strategy in array. The availability of measure for the assessment of disease activity, they have been developed and correlated well with the progression of joint damage and physical function. Second, it had gradually become clear that effective treatment has an influence on damage progression, and early therapy offers advantages in the outcome. Third, it became evident that remission was attainable and that progression of joint damage could be stopped if this state was reached and sustained. Finally, strategic trials using established measure of disease activity to guide and mandate therapeutic changes revealed high efficacy compared with an unguided treatment approach. And the first of these trials is the DECORA study in 2004, where it was clearly demonstrated patient outcomes are improved if a practice to aim for minimal levels of disease activity by frequent adjustment of therapy according to quantitative indices is implemented, leading to the idea that treatment strategy could be important and probably more important than the medication itself, as you can read in this important commentary. So what is the treat to target strategy? The treat to target strategy is based mainly on 3 pillars. Set the treatment targets, frequently measure the level of disease activity, and adjust therapy if targets are not achieved. So as you can see, treat to target is not about drugs. It is about strategy, it's about timing, about methodology, and you can apply this strategy in any setting and with any kind of availability of treatment options. A recommendation for the application of the treat to target strategy in rheumatoid arthritis were developed several years ago, and this work was mainly guided by Joseph Smolen. And this slide is just to show you that in 2016, in the update of the 2016 recommendation, we have a level of evidence of 1B, which means clinical trial, for several recommendations. Now, what about JIA? As you can see here, we have a large number of drugs to achieve remission, but we have to use them in the best possible way. I really recommend you to read this review from our German friends. As you can see, again, we have a large number of drugs. Probably not all of them are available in any country, in any setting, but we have the potential to achieve remission probably in most of our patients. So we felt a few years ago that we were ready to implement a treat-to-target strategy for JIA, and we did it thanks to the effort of an international task force of pediatric rheumatologists. In 2018, we developed the treat-to-target recommendation for JIA. I gave a contribution to the literature review to support the recommendation, and the category of evidence, as you can see here, ranges from 2B to 5, so not clinical trials, but in the best case, we have cohort studies. We have 8 recommendations, which were preceded by 5 overarching principles. So one may say that some treat-to-target was already present in the ACR guidelines for the management of JIA that were developed now more than 10 years ago. And yes, probably yes, in part, there are treatment targets which were devised by a panel of experts. There is timing and indication to escalate therapy if targets are not met. But is this real treat-to-targets? Of course, I think no. And so to explain you, I want to go back to our treat-to-target pillars and to the overarching principle of the treat-to-target strategy in JIA, and in particular to focus on the first and the last principle. So treatment targets and therapeutic strategy should be based on shared decision between the parents, the patient, and the pediatric rheumatology team. So at the beginning of the treatment, the strategy and the targets have to be clearly indicated. And in in the last overarching principle, treatment to target is based on regular assessing of disease activity, and the therapy should be adapted accordingly if the goals are not achieved. So tight monitoring of the patient. And this, I think, makes the difference between the step-up therapy and the treat-to-target strategy. So going into details, we have, as I told you, 8 recommendations. The primary target for treatment of patients is clinical remission, but minimal disease activity in some cases could be an alternative target, especially in long-standing disease, only in the most difficult cases. The target should be selected according to individual patient characteristics. Disease activity should be assessed regularly with a composite instrument. The frequency of the assessment depends on the category of JIA. For example, in the early stages of a patient with systemic JIA, probably the tight monitoring means assessing the disease activity on a daily basis. Whereas in oligoarthritis or polyarthritis patients, a visit every 2-3 months could be enough. So in all patients, at least a 50% of improvement in disease activity should be reached within 3 months, and the target within 6 months. Treatment should be adjusted until the target is achieved. This is fundamental. And once the treatment target has been achieved, it should be sustained. So now let's focus on recommendation 4, how to assess disease activity. The only validated composite measure that is available for JIA is the JDAS. Probably most of you already know what is the JDAS. It is a score which allows us to summarize the level of disease activity in one single number. As you can see here, it is given by the sum of 4 components in the original version: the physician global assessment of disease activity, the parents or the patient global assessment of well-being, a number of active joints, and acute phase reactants. There are several versions of the score based on the different active joint count. In the most simple and now most widely adopted version, we have a complete joint count. So each joint counts as 1 with a cut at 10. So when you have more than 10 active joints, you get, in any case, 10 points. So the score range is from 0 to 40. Then we have a clinical version of the JADAS-10 in which the acute phase reactant is not included. This is more feasible in an ambulatory setting, of course, and then the score range here is from 0 to 30. I'm really happy to present you the new cutoff values for the JADAS corresponding to the state of inactive disease, minimal disease activity, moderate disease activity, and high disease activity. These were published in Arthritis and Rheumatology by our group last year, and they were endorsed by the ACR criteria subcommittee. As you can see, cutoffs and disease states were devised separately for oligoarthritis and polyarthritis. We made this work, these cutoffs were based on a study which was possible thanks to the EPOCA study. Is a cohort study that Brinto allowed us to perform now a few years ago, in which we enrolled more than 9,000 patients, and we used this huge database for a selection cohort and then for validating the JADAS cutoffs. So in 2018, as I told you, the evidence supporting the treat-to-target strategy was quite weak, especially supporting the efficacy of a treat-to-target strategy in comparison to a non-steered management of GIA. What was the evidence, and do we have more evidence now? I believe that there is quite strong evidence that targeting remission or inactive disease is important in GIA. Here we see just an example, but there are others. The achievement of inactive disease in the first 5 years of the disease predicts better patient outcomes in terms of limited joints, in terms of functional ability and articular damage. This is one example, but I don't think I have to convince you of this. But this was not direct evidence for treat-to-target strategy. We have some indirect evidence coming from a few strategic trials performed in the last decade. The first is TREAT from the US, from the Carol Wallace group. In 85 polyarticular GIA patients, they compared the efficacy of 2 treatment regimens. Arm 1 was etanercept and methotrexate and prednisone together. Arm 2 was methotrexate as a first line and then escalation of therapy. In both arms, there is a treat-to-target approach. At month 4, if patients do not achieve ACR 70, they have to escalate therapy. The target at month 6 is clinically inactive disease. And again, with treatment adjustment, if the target is not achieved. And this is just to show you that those were very severe patients with a median of 18 or 25 active joints in the 2 arms. The results were not what the research group had hoped. There was a trend toward a high rate of induction of clinically inactive disease in a more aggressive treatment arm, but the difference was not significant. But the authors conclude that both treatment regimens demonstrated dramatic effectiveness in this severe group of childhood arthritis patients. And both treatment regimens were based on, at least partially, on a treat-to-target strategy. And then we have a more recent study the best for kids from the Netherlands. Here, treat to target is in the title of the manuscript, and we have 3 arms. Arm 1 is sequential monotherapy, methotrexate or sulfasalazine. Arm 2 is methotrexate plus 6 weeks of prednisolone. Arm 3 is methotrexate plus etanercept. And we have targets, ACR 50 at 3 months, inactive disease at 6 months. Here, the authors show the percentage of patients in the various treatment regimens at the different time points. As you can see, the light blue bars or red purple bars, at last follow-up, 50% of patients were on an anti-TNF therapy in all arms. White bars are inactive disease without medications. In the end, the results of the trial show very satisfactory results in all 3 arms in terms of inactive disease here, or in terms of JDAS score here, with 70% of patients achieving inactive disease and nearly 40% stopping all DMARDs after 24 months. Why? It was quite surprising. Different arms, same results. The authors conclude that this was due to the treat to target strategy. So same conclusion as the treat study. The authors point out that more than half patients receive a biologic DMARDs with no relevant adverse events, but this is probably the other side of the coin. That is, it is likely that with the treat to target study, with the treat to target strategy, we will probably prescribe more drugs in some phases of the disease, but we aim to spare drugs and improve outcomes on the long term. Clearly, this is still to be demonstrated. And what about systemic arthritis? Here, I will not show you a clinical trial because we haven't, but a very important cohort study from the Dutch group of Utrecht. They described the effectiveness of first-line treatment with anakinra in new onset systemic JIA. It's only 20 patients. We have time points, 1 week for NSAIDs, fever at day 3 with first-line anakinra, ACR 90 at day 90, and so on. Considering the whole cohort, including those achieving only, those receiving only IL-1 blockade and those needing steroids when targets were not met, well, the results are quite impressive. History to target the Holy Grail. Somebody probably says no. I invite you to read this commentary from 2 eminent patient-parent research partners, Kasper Schumacher and Martin de Witt. And they criticized the focus on disease activity and disease activity scores, forgetting relevant elements such as pain, fatigue, morning stiffness. Of course, I do not completely agree with them. The JDAS, as you have seen, includes a parent and patient global evaluation, which accounts for 25% of the total score. But I think they raise some important point, and interesting discussion could start on this very important issue. This is my final slide. Several studies are now on their way comparing treatment strategies in JIA. One is this, coordinated by Printo. As of now, it is only Italian, but we are trying to make this study at least European. The study is coordinated by Printo. And here we will compare a treat to target approach with an early aggressive therapy. So 2 different treatment strategies, not about drugs, but again, about strategies. So in conclusion, treat to target strategies based on setting the target, measuring the level of disease activity, and adjusting therapy if targets are not achieved. We have strong evidence of the effectiveness of treat to target strategy in chronic diseases such as RA, but only indirect evidence supporting treat to target in JIA. More studies are needed to demonstrate safety and efficacy of treat to target in JIA, and they are underway. So with this, I thank you for your attention. I wish again to thank the scientific committee for the kind invitation. Of course, I would have loved to meet you all in person in a city rich of culture and history such as Tehran, and I really hope I will have the opportunity to visit your country in the future.
Aylar, microphone, we don't hear you. Okay. So, thank you very much, Alessandro, for presenting such a beautiful talk on one of the main avenues of the therapy of JIA. Treat to target is a very novel strategy, which, as Alessandro said, is not necessarily based on a particular drug, but concerns the best way to combine and to introduce therapy which is aimed to reach the objective.
Could you hear me now?
Yes, I hear you now. Okay.
Yes, thanks a lot. So sorry for this inconvenience, yet it was awesome. Dear Professor, if you let me, I can share the presentation of Dr. Silvia Manzoni.
Very well. Go ahead. Remember to ask questions through the chat. We already got two, not questions, but two messages.
Good afternoon and good evening. I thank the organizers of this wonderful event for the kind invitation and the moderator for the introduction. In the next about 20 minutes, I will try to give you an overview of the advances and challenges in musculoskeletal ultrasound in pediatric rheumatology, particularly in juvenile idiopathic arthritis. In the past decades, there has been important progress in the management of juvenile idiopathic arthritis, which includes the shift towards early aggressive interventions and the development of new therapeutic agents and combination treatment strategies. Early detection of joint inflammation and damage became milestones in the assessment of JIA patients. Over other imaging modalities, musculoskeletal ultrasound showed to be particularly feasible and useful. Indeed, musculoskeletal ultrasound, it is quick, it doesn't expose the child to ionizing radiation, it doesn't require sedation or general anesthesia, it allows for multi-site assessment in the same session, comparison between symptomatic and asymptomatic sites, dynamic study. Moreover, it is well accepted by both children and their parents, and it is the only imaging technique that can be coupled with a conventional approach to patient assessment in the clinic. Its recent widespread has also been due to the increasing availability of ultrasound machines with high-frequency probes that became less expensive than before, and of some educational events on musculoskeletal ultrasound specific in children. Musculoskeletal ultrasound allows for exact identification of inflamed sites in those joint regions that can be difficult to assess only clinically, especially in younger children, such as the ankle and the wrist, where the joint recesses cannot be clearly distinguished by tendons, for instance, as we can see in these slides, where we can find an effusion and hypertrophy of the tibiotalar anterior recess, and also a fusion of the tibialis posterior tendon sheaths. Similarly, in these other pictures on the right side of the screen, together with the wrist synovitis, we can easily detect by ultrasound a marked synovitis, both in the longitudinal scan and in the transverse scan. Indeed, musculoskeletal ultrasound can be of utmost importance in identifying inflammation, also in the joint most commonly involved in JIA, which is the knee. In fact, apart from the suprapatellar recess, other joint structure, like shown in this slide, may be involved in the inflammation process and may be disregarded if not adequately checked. Here we can see a deep infrapatellar bursitis of a young boy of 3 years old, and here a patella tendon enthesitis in a young lady of 13 years old. Although for several years ultrasound and clinical assessment of synovitis have been compared each other for proving superior sensitivity in detection of early signs of inflammation, I would like to softly drive you from a black and white thinking, like ultrasound is superior to clinical assessment, or clinical assessment remains the gold standard since ultrasound is too much operator and machine dependent, to a wider range of color of thinking. I myself contributed to this kind of competition. However, I think that it's time for change somehow this competition about two types of assessment. For sure, musculoskeletal ultrasound is a valuable support in defining and detecting bone irregularities and cartilage alteration, and this can happen earlier than conventional radiography. On the other hand, musculoskeletal ultrasound can provide information only on bone or cartilage profiles that are accessible to the ultrasound beam. As we can see here, irregularities do not appear only late in the disease, but can be detected also in relatively young children with juvenile arthritis. It's clear that musculoskeletal ultrasound is a valuable support in guiding injection procedure, particularly in small joint structures such as the tendon sheaths, here of the ankle, or here of the tender flexor tendon digiti propri, or very small joints which could be difficultly accessible blindly. On the other hand, musculoskeletal ultrasound can provide a lot of help also in the injection of wide joint recesses, such as the knee, when synovial hypertrophy, for instance, overwhelms a fusion, like it is shown in this slide. Here you can see a widening of the suprapatellar recess, which is mainly represented by synovial hypertrophy rather than synovial effusion. And this could make imply some difficulties in performing correctly the procedures. Several peculiarities must be taken into account in musculoskeletal ultrasound in children for avoiding unpleasant mistakes. First of all, younger children display an overrepresentation of cartilage compared to the ossified bone. And this appears as black or anechoic as fluids. And again, it reduces the availability of anatomic landmarks. So we have not to misinterpret black as fluid collection. Secondly, joints in children are physiologically vascularized. Positive color or power Doppler can be detected as in inflamed sites, but must not be interpreted as inflammation. Finally, irregularities of ossification centers must not be confused with erosions, as we can see here. This type of appearance fit very well the definition of erosion that have been developed for rheumatoid arthritis, but be careful, do not misinterpret this kind of findings in order not to judge as presence of joint fusion, because you see black with hypertrophy, high inflammation, and associated with erosion, whereas all these are simply physiological appearances of children's joints. It becomes clear that accurate knowledge and application of ultrasound physics and machine settings are mandatory, as well as deep knowledge of children's anatomy changes over time, specific musculoskeletal ultrasound training in children, and continuous retraining. It is extremely important to look at, to know how to look at, and to know what to look for. In order to do this, to rely on musculoskeletal ultrasound as valid tool for the assessment of arthritis in children, as occurred in adults with rheumatoid arthritis or chronic arthritis, a tremendous standardization and validation process started several years ago and is still ongoing. As you can see, it's about more than 10 years that several joint international efforts combined in understanding which were the needs perceived with regards to pediatric musculoskeletal ultrasound. Then it came that it was mandatory to standardize the acquisition and interpretation of images. For this, compared to the adult counterpart, it raised the need of define normal joint components. Keep in mind that this has never happened in for the adult features of joints. And then there have been several attempts in describing ultrasound appearance of joints, and then cases in healthy children. Then in general, in some joints for the knee, and then the shoulder, the hip joint, then the vascularization, the wrist, the elbow, and so on. At the same time, there were developed definition also of ultrasound detected synovitis. And then more recently, there has been an attempt in testing the reliability of these definitions in juvenile idiopathic arthritis patients. Let's see what are the available data we can rely up to now. First, we can find several references for healthy children and adolescents. As we have just mentioned, we have definition for the sonographic features of joints, and also we have several proposed standardized acquisition protocols and scoring system. Some are relative to only one joint, such as this group who aim to describe the acquisition protocol and scoring system for the knee, whereas others consider several joints at the same time. Some of the first papers on the description of joint recesses and tendon sheaths in healthy children explored particularly the joint, the hip joint, the knee, the wrist, the MCP and the PIPs from the 2nd to the 5th digit, in quite consistent group of healthy children and adolescents, 60 of them, with different age ranges. Again, more recently, it was described, there were described ultrasound references for the pediatric wrist in over 100 of healthy children aged from 6 to 16 years. The German colleagues gave great efforts in providing data on healthy children and adolescents. First, with the description of age and sex-related findings in B mode of the knee in over 400 of healthy children and adolescents. Then in the hip, keeping in mind an historical study that was made was published in 1996 about the anterior recess of the normal hip in 166 asymptomatic children, which remains one of the most important publications on references on healthy subjects regarding this topic. Then the German colleagues explored the shoulder with the description of intervals of the cartilage thickness of the left and right shoulder joint in female and males, the capsule bone distance and the capsule thickness. The elbow joint, again, with the bone capsule distance, the cartilage thickness, and the capsule thickness. And in more limited cohorts of healthy children and adolescents, more recently, there have been description of entheses and bars at several joint regions, namely in this paper of 2015 for the elbow, the knee and foot, in lower extremity entheses, and again in 41 healthy children and adolescents for the quadriceps tendon, patellar tendons, the Achilles tendon, and the plantar fascia. Interestingly, in the paper published in Pediatric Rheumatology in 2019, the authors outlined that Doppler signal close to the entheses, which may recall enthesitis as per definition in adults, can be found in healthy children aged 12 and 14 years, which were much more detected in the quadriceps and distal patellar tendon entheses than in the other entheses explored, suggesting that this kind of features should be carefully considered when examining children and adolescents. Let's see what kind of data we have we can rely on regarding definitions of pathology. In the recent years, there has been the introduction of preliminary definitions for the sonographic features of synovitis in children, which represent the first important step for considering synovitis in children. It differs from the adult definition, since synovitis, according to this kind of definitions, can be diagnosed on the basis of B-mode findings alone, and cannot be diagnosed based on color and power Doppler findings. Color and power Doppler signal must be detected within synovial hypertrophy to be considered as a sign of synovitis. What is the interest for us as clinicians and researchers? Does or can musculoskeletal ultrasound guide therapeutic decision in children, specifically in juvenile idiopathic arthritis, or it is mission impossible? Let's see. Very recently, the French group produced data on validation of the pediatric musculoskeletal ultrasound definitions of pathology regarding synovitis in grading. The authors' results suggest that this definition is applicable and the scoring system is useful in both in clinical practice and in multi-center studies. There has been some attempts in evaluating the sensitivity to change of musculoskeletal ultrasound according to intervention, namely the use of intraarticular glucocorticoids injection, but also with biologic treatments and other systemic treatments. However, these data have been produced before the a definition of synovitis and proposed acquisition protocols have been published. So different type of definitions, both of synovitis and also for the acquisition of images, do not allow us to generalize this kind of results. Very importantly, some attempts have been made regarding the predictive value of musculoskeletal ultrasound in predicting potential flares in children with juvenile idiopathic arthritis in remission or in inactive disease. However, results have been controversial. Some papers indicated that the ultrasound examination may play a role as a predictor of relapse of patients, where other studies do not confirm this finding. Of note, very recently in the recent press 2021 meeting, there has been a report regarding the integration of musculoskeletal ultrasound findings and serum biomarkers for the prediction of disease flare. And maybe this may be the realistic way to consider these controversial findings. What I mean, what we see is real, but what does it really refer to? We need to understand, to know findings, to correlate with clinics, to standardize our evaluations in a virtuous circle for improving our knowledge in this view. On the same way, we have to always keep in mind that there are not peculiar findings of synovitis that can allow us to make a precise diagnosis, apart from very, very few conditions. Indeed, these three images shown in these slides show a synovial widening of the hip, which are quite similar among them, but they refer to completely different diagnoses, as you can see here. Similarly, we can find that ultrasound findings completely fitting the findings that we may detect in juvenile idiopathic arthritis patients can belong to complete different diseases, such as in this case with autoinflammatory disease and mixed connective tissue disease. So we have to always correlate with the overall clinical scenario. So at the end of this talk, I wish to have convinced you that we cannot think about ultrasound as good or bad tool. We can completely rely on this, or we cannot trust on ultrasound findings. but I would rather consider an integration of information with the clinic, with biomarkers, in the view of the treat-to-target strategy for better understanding what is going on in the joints of our patients, and to address more wide and complicated condition that cannot be simplified. So, in conclusion, I myself wish to keep on learning, to see, to interpret correctly, to know how to deal with interpretation. And I invite you to do the same. And I am available for question if you have anyone. Thank you for your kind attention.
Thanks a lot. It was awesome. Dear Professor Ravelli, we are with you.
Okay. Thank you very much, Silvia, for your excellent talk, which highlighted, as it was mentioned in the title, the importance of ultrasound, which is essential for diagnostic purposes, but also to monitor the course of disease activity over time, but also to evaluate the effectiveness of therapies. But you also highlighted, emphasized the challenges that might be related to this investigation, which is operator dependent, and whose role in the treat-to-target strategy is still unclear. Anyway, it is an extremely exciting field, and I hope that your presentation, I'm sure that your presentation increased the interest for the application of ultrasound in daily clinical practice in children with GIA, juvenile idiopathic arthritis, but also in children with other rheumatologic conditions which present with arthritis. So I think we should now proceed, if you agree, with another Silvia Rosina from Genoa. She's an expert in many fields, but in particular in juvenile dermatomyositis, which is her beloved area of clinical and research interest. And Silvia has published a number of papers on clinical assessment disease, which is extremely important, and she has proposed most of the recent measures that are applied in the assessment of this state in children with this condition. Please, Silvia, are you presenting live or with?
Yes, if possible, I would prefer to.
Okay. Okay.
I try to share my screen.
We'll enjoy your live presentation.
Yeah.
Thank you.
You're welcome. Okay. Can you see my screen?
Yes, very well.
Okay.
Nice talk, as usual.
Thank you, Angelo, for your kind introduction. And first of all, I would like to thank the organizer for the kind invitation to take part of this great event. So as already mentioned, I will talk to you about juvenile dermatomyositis, or JDM. JDM is the most common and recognizable form among the so-called juvenile idiopathic inflammatory myopathies that are an heterogeneous group of rare systemic autoimmune disorders that can involve multiple organ systems, but that are defined by the presence of chronic muscle inflammation. In JDM in particular, both skin and muscle are mainly affected. This disease can be associated with the peculiar and largely mysterious complications. It's a rare disease whose average age at onset is around 7 years, and whose onset is usually insidious. A patient can show either a monocyclic or a chronic polycyclic course of disease, but there are also children that show a persistently active disease. As regards the diagnostic criteria, the historical ones are the one published in 1975 by Owen and Peter. For the diagnosis of definite JDM, these criteria require the presence of a pathognomonic skin rash, +3 of the other 4 criteria that are the presence of symmetric weakness of the proximal muscles, the presence of elevated serum levels of muscle enzymes like CK, LDH, or transaminase, the evidence of myopathic changes on electromyography, and lastly, the presence of a muscle biopsy documenting histologic evidence of necrosis and inflammation. Just to have a quick view, this timeline shows you the fact that with time, many different diagnostic and classification criteria have been proposed. And I want to focus your attention on the last one published in 2017, the so-called EULAR ACR classification criteria for adult and juvenile EMs and the major subgroups. These are the last one published and are quite important together with the Bowen and Peter criteria for the classification of juvenile myositis and especially JDM. Going to the clinical manifestation of disease, first of all, let's focus on the skin manifestation. Children usually show the so-called heliotrope rash, that is in lilac or reddish discoloration of the eyelids that, as you can see from the pictures, can also be associated with quite impressive palpebral edema. Patients can also show a malar rash, like in the picture you can see on the right-hand side. Other peculiar skin manifestations are the so-called Gottron papules that are located on the metacarpophalangeal and interphalangeal joints, and the so-called Gottron sign that is usually located on the extensor surfaces of knees and elbows. As you can see, this rash can be more or less red, and it is very important to pay attention to the fact that most of children with this disease at the beginning are usually diagnosed with atopic dermatitis or psoriasis because of the similarities that disease can have with the other diseases, and because of the fact that most of the time the onset of the muscular manifestation are insidious and not so clearly expressed. Children can also present with other rashes. For example, the retroauricular location of rash is quite typical of JDM, and also the presence of a rash on the neck is quite particular and peculiar. These are other pictures of Gottron sign. As you can see, also the perimalleolar area can be involved. And these are other pictures regarding nails and the fact that children can show periungual erythema and quite impressive nail fold capillary changes that can be seen sometimes just by capillaroscopy and video capillaroscopy, as in the second picture, or sometimes can also be seen with naked eyes. And another sign that is not so well known but quite peculiar for JDM is the presence of cuticular overgrowth that is not present in all patients but can be a recognizable sign of disease. Children with the most aggressive forms of disease can present also with more vasculitic lesions, vasculitic manifestations, like on the eyelid of this child, or on the lower limbs of the central child in the picture. As you can see, these are very impressive and also aggressive. Going to the muscular involvement, what is the characteristic of JDM is the presence of a weakness that is more proximal than distal. And it's very important to remember that it can also involve the bulbar muscle. So children can present with dysphagia, rhinolalia, and so because of the involvement of these bulbar muscles. So it's very important to look for these signs of disease. What is very important in children with JDM is to try to quantify at every clinical visit the level of muscular involvement. This is not so simple with children because children are usually able to cooperate with us in with strength assessment when they are more than 5 or 6 years of age. The two most used and classical strength assessment tool in JDM are the so-called MMT8, Manual Muscle Testing 8, that comprehends the evaluation of the peak force of 8 muscle groups. And the other one is the CMAS, Child Dermatomyositis Assessment Score, that is quite a long tool that comprehends the performance of 14 maneuvers that not only evaluate the peak force of the child, but also the endurance of the child in performing these maneuvers. And this CMAS, for example, comprehends the time of head lift, so the time that the child can keep the head up from the level of the bed, and the normal time is 2 minutes, and also 6 abdominal maneuvers. What is important to say it's also that in juvenile dermatomyositis, it's quite typical that we have an involvement of the axial muscles, so the neck and the abdominals. And so it's very important also to keep an eye on these muscle groups. These are usually, or most of the patients, muscle groups that are mainly involved and that can recover just later on in the when the child gets better. In order to have a tool that can be used in clinical practice, in routine clinical practice, because as you can all imagine, the application of both these tools is not possible because of time restrictions in daily care. Recently, our group has proposed this new tool that is so-called hybrid MMT-CMAS or HMC, that, as you can see, is composed by the 8 maneuvers of the MMT8, so the evaluation of these 8 muscle groups, plus 3 maneuvers taken from the CMAS, that are the 6 sit-ups maneuvers, the so-called floor rise, and the time of the lift. As you can see, the score range of this muscle tool goes from 0 to 100. And this requires not such a long time to be used in clinical care. So it's something that we can apply in every single visit of the patient in order to follow in clinical practice, which is the level of weakness of the patient at every visit, and also to compare which is the evolution of disease according to the therapies that we are doing. I already mentioned that JDM can be associated with different complications that are quite peculiar and quite mysterious. And first of all, this is calcinosis. As you can see from these pictures, calcinosis can be more or less diffuse. And as you can imagine, when it's very diffuse, this can be very, very disabling for patients. It can have quite a huge impact on the quality of life of patients. And another problem with calcinosis is the fact that it can be over-infected, so the infection problems, and sometimes these calcium collection can drain spontaneously. And these are all to be focused and followed up very cautiously. Another complication that is not so common as calcinosis, and it's even more mysterious, is the so-called lipodystrophy. So children can also present with this very particular and abnormal distribution of fat. And this is normally associated with an imbalance from a metabolic point of view with insulin resistance. The most aggressive forms of JDM can also be associated with visceral complications in terms of interstitial lung disease, heart involvement, and also gut involvement. Like here on the right-hand side, this was a patient with gut perforation because of JDM. The whole body MRI is a tool that in the last few years emerged as a very important one in the evaluation of children with suspected JDM. So both in the diagnostic process, but also in the follow-up. As you can see from these pictures, the inflamed muscles appear as white in the steer sequences. So white means inflammation. And as you can see on the right-hand side, our group quite recently proposed a steer whole body MRI total muscle score that has been demonstrated to be well correlated with the activity of JDM patients. Just to give a few examples, as you can see, the distribution of inflammation of muscles on whole body MRI can be patchy, as is usually described on books about JDM, but it can also be more diffuse and homogeneous, like in the second picture. And what I want to focus on is the fact that repeating this exam with time, we can follow up children very well, because, for example, on the right-hand side, you can see a child at the disease onset with very important and diffuse inflammation of muscles, and after therapy, so in a remission phase. And you can see that all these abnormal signals have disappeared. Muscle biopsy is still quite an important tool in the diagnosis of JDM. What is quite peculiar in JDM is the presence of perifascicular atrophy. And quite recently, it has been proposed this score system for muscle biopsy evaluation in patients with juvenile dermatomyositis that comprehends 4 domains: an inflammatory domain, a vascular domain, a muscle fiber domain, and the connective tissue domain. And the application in the reporting of muscle biopsy of this score system can help in harmonizing and the results of muscle biopsy. And as you can see here, also the authors propose a potential use of this tool in clinical trials in order to have more harmonic population of patients enrolled in trials. As regards autoantibodies, the 60 to 70% of patients with idiopathic inflammatory myopathies carry an identifiable myositis autoantibodies that can belong to the group of the so-called MSA, or myositis-specific autoantibodies, that are autoantibodies just found in myositis, or to the group of the so-called myositis-associated autoantibodies that are also found in other conditions in which myositis can occur, for example, SLE. The detection of more than one MSA in the same individual patient is extremely rare. What is quite clear now is that each kind of MSA tends to be associated with a particular peculiar clinical characteristic of disease and the clinical course. And so we think that the detection of these autoantibodies can be useful and in the follow-up of patients and in prediction of the course of disease, even if they are not perfect biomarkers. So by themselves, they cannot predict which is the course of disease, but they can help. They can give us also an idea on what to focus in a particular patient. So, for example, the 23 to 30% of patients with JDM turned positive for anti-TIF1 gamma autoantibody. These children normally have show signs of a more severe cutaneous involvement, can develop generalized lipodystrophy, and most of the time they show a chronic illness course. 20 to 25% of children present anti-NXP2 positivity, and these children are thought to be more prone to the development of calcinosis and, in some cases, gastrointestinal ulceration. these kind of children normally show a monocycline disease course. As regards anti-Me2 autoantibodies, these children are a minority, and usually they present with mild JDM, with classic rashes, and they have usually good prognosis. And finally, anti-MDA5 autoantibodies can be associated with amyopathic dermatomyositis, so children can show skin disease, but not signs of muscular disease. And in particular, in the Japanese population, these autoantibodies have been associated with an early diagnosis of rapidly progressive interstitial lung disease associated with high mortality. Just to have a quick look to our cohort of JDM patients, in a small cohort of 39 patients evaluated for the validation of a tool that I will present you in a few minutes. 82% of them, we had the MSA status available. In 62% of them, the MSA turned out to be positive, with percentages that are similar to the ones reported in literature. On the right-hand side, you can see the example of a child, of a girl, with anti-TIF1 gamma autoantibodies. As you can see, this girl had some quite impressive vasculopathic rash, and she presented also with quite a significant involvement in the muscle, so with low MMT8 and CMAS, but the level of CK was low, as also reported in this group of patients, anti-TIF1 gamma positive. This is the tool that I was mentioned before, the so-called Juvenile Dermatomyositis Activity Index, or JDMI. This is the first composite disease activity score so far proposed for juvenile dermatomyositis. It has been recently proposed and published by our group, and it was developed in a similar way to the already mentioned JDAS for JIA. As you can see, we proposed 6 different preliminary versions, all of which comprehends the physician global assessment of overall disease activity on a 0 to 10 scale, the parents' global assessment of overall well-being on a 0 to 10 visual analog scale, an item evaluating the muscle involvement, that could be the agency expressed in the size, or the MMT8 or the CMAS, as you can see in the different versions, and a fourth item measuring or assessing the skin involvement. And you can see it could be either the skin VAS or the skin component of the DAS, disease assessment score. So the sum of these 4 items gives a total number that can go from 0 to 40 for JDMI 1, 3, and 5, or from 0 to 39 for JDMI 2, 4, and 6. And this number can give us an idea of the level of disease activity in that precise moment in the single patient. So can help both the physician and the family to understand which is the level of disease activity in that precise moment, can help the physician in the follow-up of the single patient to understand if the patient is getting better and how much, and can also help in the application of the treat-to-target strategy also in JDM patients, and not only in JIA, as already mentioned. Going to the long-term outcome of disease, we have to say that before corticosteroids, the outcome was very severe, with 1/3 of the patients that died, 1/3 that had serious functional morbidity, and just 1/3 that recovered without complication. With the advent of corticosteroids, there was a marked decrease in mortality, with improvement in functional outcomes, and today the mortality rate is around 2 to 3%. But if we look to patients with JDM followed up for a while, for example, in this study, they followed up 65 JDM patients for a median of 7 years. Even if the children, most of children presented good functional outcome, and death was an infrequent outcome, just in 1.6% of patients, what is important to underline is that the patient showed frequently ongoing disease. 40% of them had still a rash, 23% of them was still weak, and 35% of them was still on medication. So the outcome of disease in the medium to long term is not brilliant for every patient. In terms of treatment, the treatment of JDM is a real challenge, as patients may have severe muscle weakness, notable skin rashes, and, as already said, life-threatening organ involvement. What is true is that we have very few large treatment trial results available, and that extramuscular disease manifestation might limit the use of specific immunosuppressive agents. Both conventional therapies and biologic therapies can be used, and what is more and more clear is that muscle weakness might persist even when inflammation and muscle damage have resolved. And so, nowadays, the role of non-immune pathways has been underlined also as possible targets of treatment. What is worldwide recognized that the initial treatment with a combination of corticosteroids and methotrexate is considered a standard of care by most experts for children with newly diagnosed with JDM, and it is supported by both trial evidence and consensus. So a corticosteroid treatment in all cases of JDM. They are used with different starting doses and regimens. Physicians use different tapering schemes, and we have to remember that they have relevant side effects, especially in children, and they are associated with high relapse rates in monotherapy. The most frequently used preparation are oral prednisone, IV methylpred, and also IV pulse methylpred that is indicated in acute and severe illness, in the presence of dysphonia, so as already said, signs of bulbar muscle involvement, or for example, interstitial lung disease or gastrointestinal vasculopathy. Methotrexate is often used in combination with glucocorticoids as initial therapy, as a steroid-sparing agent, and its efficacy in association with the glucocorticoids in the treatment of new onset JDM has been showed and demonstrated by this trial that has been published on Lancet in 2016, when the 139 patients with JDM, newly diagnosed with JDM, were divided into 3 treatment arms that were prednisone versus prednisone plus cyclosporine A versus prednisone plus methotrexate. And what the authors demonstrated, this was conducted by Printo, is that the combined treatment with prednisone and cyclosporine or methotrexate at disease onset is more effective than prednisone alone. And they also showed that the safety profile and steroid-sparing effect favor the combination of prednisone plus methotrexate over the other 2 treatment arms. Other second-line drugs that can be used in JDM are cyclosporine A, that is a calcineurin inhibitor with a long history of use, whose efficacy has been recently supported from the trial I just showed you. This is an option, especially if methotrexate is contraindicated or not well tolerated. Hydroxychloroquine is a commonly used drug, used in particular when the skin disease is more expressed, even if the evidence of its efficacy is limited. Intravenous immunoglobulins are a very useful drug. They have an immunomodulatory effect, even if the precise mechanism of action isn't known. There are no formal clinical trials in JDM, and also the regimens that are used can be different. Usually we give a dose of 2 gram kilo, maximum 60 to 70 gram every time, monthly for 6 months, and then every 3 months. These are beneficial in combination with other immunosuppressive agents, but they are also quite expensive, and they require a long administration time time, so they require the admission of children in the hospital. They can be very helpful in the treatment of difficult skin disease, and they are to be considered in children with dysphagia. And recently, a trial in adult dermatomyositis has been launched for the evaluation of the administration of immunoglobulin subcutaneously. That can be a good option also for children. There are many other medications that can be used in the treatment of juvenile dermatomyositis patients, like azathioprine, cyclophosphamide, mofetil and thalidomide, and also biologics like TNF inhibitors and rituximab. Bisphosphonates have been used for the calcinosis, the treatment of calcinosis, even if the results are not so clear and not always so brilliant in all patients. In the last few years, there have been reports about the use of JAK inhibitors also in JDM. And more simply, what I want also to point out is that it's very important, especially in a subgroup of children with JDM, to recommend sun care avoidance. So there are children with JDM that show a reactivation of disease after sun exposure. So it's very important to recommend to all patients to use sun creams with high sun protective factors. And with this slide, I finish my presentation, and I thank you very much for your kind attention. I would be very happy to answer your eventual question from the audience, and we wait for you all here in Italy. Thank you very much.
It was awesome, dear Professor. Thanks a lot.
Thank you.
So thank you very much, Silvia.
I stop my sharing.
For this fantastic talk, which covered all main aspects of the disease that I think is one of the most fascinating illnesses of pediatric rheumatology. And it is important that she emphasized that the regular quantitative assessment of the disease state with standardized measures is essential, is extremely important, is fundamental to care children in the proper way and to make sure that treatments are efficacious enough. So let's then close this session with my talk on lupus. I will, as I was requested, I will give it live. Let me share the slides, and then I remind you that we will have a discussion at the end of the session after my talk. 1 second, just okay. I guess you see my slides.
Yes, dear Professor.
My task, the final task is to discuss with you the problems that are and the issues that are raised by the heterogeneity, the clinical heterogeneity of lupus when it develops in children and adolescents. Let me start reminding you that lupus is a multisystem inflammatory disease which may virtually affect any organ and system in the body. It is well known that it's clinically heterogeneous, and indeed its clinical spectrum may range from cases which develop multi-organ involvement since the beginning to cases who, however, start in oligosymptomatic or even in monosymptomatic form. And based on that, it is clear that the diagnosis of SLE may be challenging, particularly in the cases who present in a mono or oligosymptomatic way, or if they develop non-classic clinical manifestations. So this the protean, the polymorphic nature of lupus is well exemplified by this mythologic figure. I don't know if you are familiar with that. The Hydra of Lerna, it was a 9-headed snake which was killed by the famous hero Hercules after a strenuous fight in the context of one of his 8 labors. And this figure, in my view, exemplifies well the polymorphic nature of lupus, which is really one of the most protean, multifaceted diseases of medicine. It is clear that when lupus presents with its classical clinical features, particularly malar rash or CNS involvement, or the signs of proliferative nephritis with acute polyarthritis or with serositis, either pericarditis or pleuritis, and when the classic autoantibodies, anti-nuclear antibodies and anti-DNA antibodies are found in the serum. So in these cases, the diagnosis is simple. It can be made in a straightforward way, even by a physician who does not have a particular expertise in rheumatology. But the difficulties in the diagnosis of lupus were already recognized by the international committees, international organizations many years ago. And indeed, the American College of Rheumatology, formerly American Rheumatism Association, proposed the criteria to help clinicians to diagnose lupus. These criteria were developed to classify correctly the disease for the purposes of including the right patient in the clinical study or in clinical trial, but these criteria were also meant to provide a reference for the diagnosis in the clinical setting. So the first set of criteria were published in 1982, so 40 years ago, and then this is the revised version. In the recent years, there have been other efforts to develop criteria for lupus, which were more updated but also more complex. So these criteria remain a mainstay for the clinical diagnosis or classification of the disease. So as I guess you all know, this historical set of criteria, which include 11 features, 4 were skin or mucosal alterations, then there is arthritis, nephritis, 2 types of encephalopathy, which may manifest with seizures or even with psychosis, with psychiatric symptoms. Then there is serositis, pleuritis, or pericarditis. And then the last 3 are laboratory abnormalities, cytopenia, leukopenia, thrombocytopenia, or Coombs positive hemolytic anemia. Then there is positive immunoserology. These criteria can be met in the presence of anti-DNA antibodies, which are specific of lupus, but when a patient might also have anti-ESM antibody, which can be a surrogate for anti-DNA antibodies, but also another surrogate is the presence of antiphospholipid antibodies detected as either anticardiolipin antibodies or as lupo anticoagulant, or as a biological false positive or standard test for syphilis. You know, the Wassermann test uses cardiolipin as a substrate. So it can be that patients with lupus and antiphospholipid antibody may prove falsely positive for the standard test of syphilis. So importantly, these antibodies can serve as surrogate for anti-DNA antibodies. That is, when anti-DNA antibodies are not detected but antiphospholipid antibodies are present, this criterion can still be met. And the last criterion is the presence of positive ANA. So based on the rule of this ACR 1997 criteria, the diagnosis of lupus can be made when at least 4 of the 11 criteria are simultaneously present. But the developers of these criteria recognize that the criteria may develop progressively over time, and indeed they admitted that the criteria could develop and be seen subsequently after the onset of the disease, but still the diagnosis can be made only when at least 4 of these 11 criteria are present together. But to give you an example of the polymorphism of lupus and the challenges that might be posed by its diagnosing the clinical setting, I will briefly present 4 very brief telegraphic cases that are quite demonstrative, quite let's say paradigmatic of the polymorphic presentation of lupus. So the first patient is a girl, is an adolescent, 12-year-old girl who had been well until the summer of that year, when she at the end of the summer season developed a slight butterfly erythematosus rash, which was worsened by sun exposure. She was otherwise well, so the family physician thought that this rash could be due to a sun burning or skin burning or skin hypersensitivity to the sun. So he or she prescribed only some creams to relieve the redness and inflammation, but nothing else, because the girl was otherwise extremely well. But then 6 months later, she developed a low-grade persistent fever, and she complained of fatigue. So her physician asked for some laboratory tests, but you see the complete blood count was entirely normal. However, urinalysis, a very simple routine test, revealed hematuria, significant hematuria, and heavy proteinuria. Then the physician went more in deep with laboratory workup, and you see C3 and C4, where this is milligram DL, were both reduced, and then both anti-nuclear and anti-DNA antibodies were present, were detectable at high titer. So let's apply the ACR 97 criteria to these patients. You see 5 criteria are met. So these patients can be classified as lupus by these criteria. So there is a butterfly rash, which is photosensitive, second criteria. There is a proteinuria above 500 milligrams per 24 hours, and both ANA and anti-DNA are also positive at high titer. So what has been the peculiar feature of these patients is that this was the classical case in which lupus presented in a monosymptomatic form with only a butterfly rash, which was misinterpreted as due to sun hypersensitivity, sun burning. And therefore the diagnosis was made only 6 months later, when the girl started to complain constitutional symptoms of low-grade fever and fatigue. Second patient, another girl a bit younger, 9-year-old. Presentation was completely different. Low-grade fever was more systemic, let's say. Fatigue, she appeared to be pale, was found to have some petechiae in the lower limbs and in the lower and upper limbs, and the physician detected a slight scleral icterus. By checking her physical, making physical exam, the physician discovered an enlargement of the spleen. There was splenomegaly. A complete blood cell count was requested, which showed leukopenia, serious anemia, and remarkable thrombocytopenia. So what was the suspicion of the physicians who saw that girl with these abnormalities? The suspicion was the one of leukemia because of the cytopenia, fever, and splenomegaly. And then a bone marrow aspirate was performed, which was negative. And it was only at that time that the scleral icterus was valued. And then the more extensive laboratory exams were requested. You see there was increased bilirubin, and the aptoglobin, which is a marker of hemolytic anemia, was remarkably decreased. The Coombs test proved strongly positive, and then the C3 and C4 were also markedly reduced. Let's look at the autoantibodies, ANA and anti-DNA, positive at high titer. Let's apply the ACR criteria. In this case, only 3 of the 11 criteria are met: cytopenia, ANA, anti-DNA. It can occur. These are classification criteria, remember, but all let's say, astute, experienced clinicians, smart clinicians would have no doubt that this lady has lupus. So what was the mild sign in this patient that was overlooked and led to suspect a leukemia and to make a bone marrow aspirate? So should this sign had valued in the proper way, this mild sign, this might have led to suspect immediately that this girl could have hemolytic anemia and could have avoided making a wrong diagnosis and also performing a bone marrow aspirate, which is an invasive procedure which could have been spared to that girl. Third case, this is a boy, 14 years old, an adolescent. He presented with fever and chest pain. He was found to have, on physical examination, polyarthritis on the small and large joints, and on echocardiography, pericarditis, pericardial fluids was detected. To complete blood cell count, you should always start with the simplest laboratory test. Showed that the white blood cell count was normal, although in the lower range of normality. ESR was increased, it is millimeter per hour, and CRP was markedly increased, and CRP was only slightly increased, 1.5 milligram per DL. Urinalysis showed a minor hematuria, but there was no proteinuria. The diagnosis here was that of systemic idiopathic arthritis based on fever, polyarthritis, and pericarditis. But, and then the patient was treated as it is done for systemic JIA. But 2 months later, he developed oral ulcers, which is not a typical sign of systemic JIA. Then the complete blood count was repeated, and then now there is leukopenia, there is anemia, but the platelet count is normal. Coombs test is only mildly positive. C3 mild reduction, but C4 is normal. But ANA positive and anti-DNA also present at extremely high titer. So no doubt that this patient has lupus. He meets 6 of the 11 criteria: arthritis, pericarditis or serositis, oral ulcers, leukopenia, ANA, and anti-DNA. So what was once more a minor abnormality which was not valued or overlooked by the physicians who saw that child? These very simple basic laboratory tests, complete blood count and acute phase reactants, clearly show that there is a discordance between a markedly increased ESR 72 and the near and low normal white blood cell count and only mildly increased CRP. This is clearly unusual for systemic JIA. In this disease, you would have seen leukocytosis and an increase in CRP in parallel with that of the ESR. And so this discordance between the acute phase reactants, particularly between ESR and CRP, is quite typical of lupus onset. So the fourth patient, again, a lady, adolescent, 11-year-old, completely different presenting symptom, persistent headache. She was attending school, was quite stressed, quite engaged getting good grades. And so the headaches was attributed to school stress. She was given analgesic medications because she was otherwise well. However, after 10 days, she suddenly developed a generalized tonico-clonic seizure episode. And then she underwent a brain MRI, which disclosed a stroke in the territory of the in the middle cerebral artery, which is quite unusual, uncommon, and worrying in an 11-year-old patient. The complete blood count showed only a slight decrease in white blood cell count, but hemoglobin and platelets were normal. Clotting times showed a normal prothrombin time, but an elongation of the partial thromboplastin time. C3 and C4 were normal. Anti-nuc antibodies were positive, but anti-DNA antibodies were not present, were negative. And the anti-phospholipid antibodies were searched for. You see lupus anticoagulant tests were present with strong positivity, and also anticardiolipin antibodies of the IgG class were also positive at high titer. Let's apply the ACR criteria. This patient would meet 4 of these criteria. Remember, CNS involvement, one of the 2 forms, seizures, leukopenia, positive anti-nuclear antibodies, and positive antiphospholipid antibodies, which in this case serve as surrogate for anti-DNA antibodies. So what was again, a minor sign that could have been overlooked, but oriented well the physicians toward the cause of the stroke, was the presence of the prolongation of the partial thromboplastin time, which was clearly due to the presence of a lupus anticoagulant that, as you know, paradoxically leads to elongation of clotting times, but is associated with the development of vascular thrombosis. So in the end, just to summarize, so the 4 patients that I have presented make up 4 completely different clinical scenarios. They look like, these patients look like as having 4 different diseases, but they all had lupus. Let's summarize briefly. Patient 1 had presented with isolated malar rash and then progressed towards the occurrence of nephritis. Second patient presented with isolated cytopenia and was misdiagnosed as leukemia initially. Third patient has had a systemic juvenile idiopathic arthritic-like onset with polyarthritis and serositis, and the 4th patient experienced cerebral stroke. So how can we suspect lupus in these challenging cases who present with monosymptomatic or oligosymptomatic form or non-typical features? So this is on the left-hand side is a movie, the Italian, very nice movie. I don't know if it was played in Iran. The translation of the title from Italian is "You must be the wolf." And on the right side, you see a wolf. You know, the term lupus is Latin and comes from wolf. It is a Latin word for wolf. And the reason why lupus is called that way is double. First, because patients with lupus, sometimes they experience a kind of lesions in the deep tip of the nose, which resemble a bite of a wolf. Or, you know, if you look carefully at the face of the wolf, you see that this feature, the white feature, resemble in that way the malar rash of patient with lupus. And this is the reason why for the name lupus. As I said in my introduction, the diagnosis of lupus is easy, straightforward when the disease presents with malar rash. Although there is an exception that Silvia Rosina showed you, dermatomyositis may also present with malar rash, which is slightly different from that of lupus, is I think less well demarcated, that it involves the nasolabial folds, which is not often seen in lupus. But anyway, in this case, the first suspicion is that of lupus. It's not difficult to separate lupus, but the Miller rash is present in only around two-thirds of children and adolescents with lupus, so patients with pediatric lupus. So let me conclude my talk by providing you some clues, some recommendations based on my long clinical practice, which might help you to diagnose lupus in these more challenging and cases which might miss the classic Miller rash. So always consider lupus when the patient presents cytopenia, when you find cytopenia in the context of an unexplained an inflammatory syndrome, because this is a discrepancy between the two conditions, but also when there is a discordance between an increase in acute phase reactants and normal or slightly reduced white blood cell count. Also, when there is a discrepancy between the two acute phase reactants, because when ESR is increased and CRP is normal or only modestly elevated. And also always include a simple test which is often neglected, aptoglobin, in the diagnostic workup of an anemia, unexplained anemia, which occurred in the context of an untypical and atypical inflammatory syndrome, and always include ANA and C3, two other simple and cheap laboratory tests in the diagnostic workup of any patient who presents with an inflammatory syndrome that is associated with unusual non-typical features. And finally, always ask for the determination of antiphospholipid antibodies in any patients, any young patients who develop a vascular thrombosis and do not have any predisposing factor for this complication. So let me conclude by inviting you all to attend the annual meeting of the Pediatric Rheumatology European Society. I'm the president of the society. The meeting will be held in Prague in September. You can participate either in person or virtually. So there are two types of registration. So you will all be welcome to participate in our meeting. So with that, I thank you very much for your attention. Okay.
It was awesome. Thanks a lot.
I wanted to give you a practical lecture, a very much clinical lecture.
You know, it was wonderful.
Thank you
Rheumatology itself is a bit difficult, but you made us an awesome session with a lot of knowledge. I think you are one of the best doctors that make the world a better place for children. Thanks a lot.
Thank you so much. Thank you so much. So shall we have 10 minutes time for a discussion?
For sure. Yes, we have time.
Okay. So I will take the liberty of asking reading the question. So the questions in the chat and asking my co-workers to respond. So first question,
for sure.
I recommend everybody to respond reasonably quickly because there are many questions. Alessandro first. So you already answered partially to these questions. So the question is how can the demanding targets of the treat to target can be achieved in settings where the expensive biologic medications are not affordable or available?
This is a great question. Of course, as I've tried to say that a few times, treat to target is a strategy and it is not about the drugs. Of course, if you have available the most effective drugs, remission and or minimal disease activity can be more easily achieved. But even if you have, let's say, more old-fashioned drugs, or if you have, you can rely on joint injection. But what is important for the treat to target strategy is to tightly assess the patient, to measure disease activity in a standardized way, because it helps. If you measure, you measure the number of joints with active disease, you give a weight with the physician global, you listen to the opinion of the patient or the parents with the parent global assessment, which are included in the JDAS. If you have a measure of the level of disease activity, it helps to stay with the plan, to point, to aim to a target like inactive disease or remission. And if you do not achieve that, you have to increase your therapy, whatever it is. Joint injection in JIA, in polyarticular JIA, in oligoarticular JIA, sometimes in systemic JIA as well, they can be very effective. They are cheap drugs. And yeah, what makes the difference is the tight assessment of the patient, and do not just rely on, yes, it is a bit better than the previous time. This makes a difference. It is very simple, but it makes a difference.
The simpler, the better. Thank you, Alessandro. So there is another question for you, which the question is, how do you get the values, the cutoffs of the various activity states in oligoarticular JIA with the JDAS 10 or 70 or so? How can you check for if the patient has reached this level of this activity in oligoarthritis through the JDAS?
I am not completely sure that I got the question. I think how we developed these thresholds.
How do you in practice
first
assess?
I see these thresholds are not those that I presented, but they are those published in 2012. It is the first version of the JDAS threshold for inactive disease and other states of disease activity. Those that I have presented are the new cutoffs, which were published early this year in arthritis and rheumatism, and they are a little bit looser than the previous ones. And they are looser because they were developed in a very large multinational data set. We had a cohort of patients that we used for the development of the cutoffs. And in this cohort of patients, we have the attending physician coming from many different areas of the world, saying this patient is in active disease, is minimal disease activity, is in moderate disease activity or high disease activity. Based on the subjective rating of the attending physician, who has the patient in front of him, we have developed these cutoffs. So you see that point one is the cutoff for inactive disease, and this is.
Okay.
Was there another question? No.
No, Alessandro. Okay.
So I hope I answered to the question.
So if anyone wants to know more about JDAS cutoffs, please write an email to Alessandro. I'm sure he'll be pleased to send you the PDF of our papers on the cutoff, the previous one and the new one. So
absolutely,
one question to Silvia this is my question essentially, because it was a very technical presentation. So are we mature nowadays to replace the clinical composite scores with ultrasound in assessing the state of remission? So which method is more reliable in your way between clinical assessment and ultrasound assessment?
I guess it's to me the question.
Yeah, for you.
Okay.
Silvia, sorry, Silvia Manzoni. Sorry. We have a.
Well, I personally think we cannot replace the clinical assessment. As far as my experience in the past years, I feel that ultrasound improved our senses, like an editorial of famous authors in about rheumatologists titled intervention about ultrasound. Ultrasound could and can improve our senses, but cannot completely replace the clinical assessment. I don't know if I've been able to communicate my personal view of ultrasound. I strongly believe that ultrasound is really helpful, but needs to be integrated with the clinical assessment and the overall assessment of the patient. This is why I think that an integration of the information that we may have from ultrasound and from the clinic and from biomarkers could really improve our attitude in defining remission, disease activity, or maybe to prevent relapses for those children who are already in remission. I don't know if I got.
Yeah, thank you, Silvia. Wise suggestion. So, Silvia, a question is: a patient has improved in all parameters, but has developed calcinosis. So disease well controlled, but there is calcinosis. Should we step up immune suppression?
So this is a very difficult question, and there was also another question from the audience also regarding calcinosis. As already told, calcinosis is not such a simple complication to be cured. So we have different treatment available, but we are not sure for the very beginning if in the single patient it will help. So I would suggest to try treatment like biphosphonates or TNF inhibitors, or there are also experiences about diltiazem or also other ongoing trial with other compounds. But now in the past we thought that calcinosis was mostly a complication of children that had for a long time ongoing disease. So what I think is very important is to switch off the active disease very soon, very early in the after onset of disease. But it's also sure that with time we have understood that there are also children that are more prone to have calcinosis, like anti-NXP2 children. So perhaps in these children we can try all these treatment, and they are not always successful. So in our center we usually we try with bisphosphonates. Sometimes we tried with the infliximab or other anti-TNF inhibitor, but not always the disease. The results are so.
Yeah. We have also tried diltiazem with
sometimes
calcium antagonist with unclear results. So another question for you, Silvia: what is your suggestion for treatment of persistent skin rash after control of systemic SID, I guess, after control of myositis, when the muscle is okay, but there is still skin rash?
I think that the use of immunoglobulins can be very helpful if we haven't used it before. Like we can also perform infusions more frequently, like every 2 weeks for 3 to 5 times, and then prolonged intervals monthly. It is also proposed to use mycophenolate mofetil, and also cyclosporine can be an option. But more recently, they have proposed also the use of JAK inhibitors also to treat just skin involvement when it's more resistant.
We have some experience on that. So another question, Silvia, you already said something, but is there any role for hydroxychloroquine beside the sunscreen, sun protection in skin disease in JDM?
Even if it has been used for such a long time, there are not so many evidence of efficacy of this drug in the treatment of JDM patients. So we don't usually prescribe now this treatment, and I think it's not. It can add, for example, also side effects to children that are already taking other drugs. So I'm not sure that it's so convenient.
I agree. Very useful in lupus, but not that much in JD. Okay. Another question is someone asked if you can share the video how to do hybrid CMAS. We should definitely make a video, Silvia.
Yes.
We don't have yet, but we promise you that next time we might send you a video.
Yes, not under 5 years of age, because
under 5 years is not easy. But if you are patient enough, in some children you can at least some maneuvers of the you can do. But you know, onset before 5 years is not that common. It can be, but it's not that common. So is there any term such as monogenic JDM, like for monogenic lupus?
No, I don't think. I think that we have to pay attention when myositis comes out very early, not to diagnose JDM instead of other like monogenic diseases like Kendall syndrome that are very rare. So for now, we know that in JDM there are both environmental and genetic factors involved, but we don't know any monogenic JDM forms, but just to pay attention that there are also other kinds of myositis that can be part of a monogenic disease.
Okay, you know interferonopathies, and you know in JDM there is now an increasing let's say impression that interferons can be involved, and this is the reason why the JAK inhibitors have been proposed essentially. So there is a question for me. In the end, I got some questions which make me pleased. No, indeed, it is about monogenic lupus who do not fulfill this criteria. You know, monogenic lupus is a particular disease which is mostly related to alteration in the interferon pathway. So this is a disease which sets a bit apart from classic lupus. And also remember what I said, that these criteria, like the more recent criteria, are classification criteria. So they are mostly used for classification purposes, to make sure that patients included in observational studies and clinical studies really have the lupus and not something else, to avoid, let's say, blurring the sample. So it's in clinical practice, the diagnosis of lupus and of monogenic lupus requires knowledge and skills. These criteria are a useful reference, but you do not have to rely too much on that, particularly when lupus develops in young children. Okay, so this is certificate of attendance. Some congratulations for us. Thank you very much. It has been a great pleasure. Okay. Your drug choice in case of Guillain-Barré occurring in the context of lupus. Oh my God, I've seen Guillain-Barré syndrome, but never in the context of lupus. But you know, it is a polyneuropathy. So in general, neurologic manifestation of lupus are treated as the underlying disease, that is with high dose steroids, because they are due to the lupus process, and immunosuppressants. Guillain-Barré, you know, you should decide on a case-to-case basis whether plasma exchange might be useful, as it is the case for, or intravenous immunoglobulin, as it is the case for the Guillain-Barré syndrome, which occur out of the context of lupus. But essentially, all manifestations of lupus should be treated focusing first on the disease process of lupus. ANA negative lupus. Okay, there was a paper many years ago in the Journal of Pediatrics which presented, if I remember well, but many years have elapsed, ANA negative lupus. Nowadays, it is clearly thought by the experts that ANA negative does not exist. And indeed, in the more recent criteria for the classification of lupus, which were published by the EULAR and the ACR together, ANA is the mandatory criterion. So patients should be ANA positive and then have the other manifestation. So if a patient with clinical manifestation suggested lupus is ANA negative, you should doubt about the diagnosis. Different is the case for anti-DNA antibody, which, as we have seen, may be negative. Okay. Alessandro, okay, you may express your thanks to those who contributed in the EPOCA study. Thank you very much. I think we are
Professor, the discussion was awesome, but I want to take a little time to introduce our dear professor in pediatric rheumatology, dear Dr. Peyman Sadeghi, who accepted our invitation to participate in this session from our side. I'm sure that he enjoyed this panel discussion a lot, as much as we did. It was so nice, awesome. Dear Dr. Sadeghi.
Thank you very much. We are very pleased and wish to thank you all on behalf also of my younger co-workers and friends. It has been really a great pleasure, the privilege, and we enjoyed so much to stay with you, even though unfortunately only virtually, and we hope, as Alessandro said, in the future to have the opportunity to visit your wonderful city and your wonderful country. I have already been there. I have enjoyed, but would be very happy to come back in the future. Okay, then thank you very much once more, and have a nice evening. It's probably you are 2 hours later of us, so it should be almost night in Iran. Okay, see you soon. Bye bye.
Thanks a lot. You see that, Professor, the team, the organizer team is here. All enjoyed a lot. Regards from here in Tehran.
Thank you so much. Bye bye, everybody.
Thank you. Bye.
Thank you.
Bye.
Thank you all. Bye.
Thank you very much.
Goodbye.
Bye.
Bye.
Bye. Thank you.
دوستان خسته نباشید.
استاد صادقی دستتون درد نکنه، بسیار ممنون.
دست شما درد نکنه.
خسته هم نباشید.
خیلی متفاوت بودیم ما.
متشکرم که صبر کردید تا پایان سشن.
نه
استاد رئیس سلامت باشید. استاد رئیس گرامی شما خوش آمدید. خیلی متشکرم. ویوا روماتولوژیست.
دکتر آقای عزیز، واقعا زحمت کشیدین همتون. ممنون از همگیتون، واقعا خیلی ممنونیم. واقعا
استاد این مرا که ما تعریفش رو شنیدیم که چقدر فوق العاده بوده، اون مرا خیلی سشن جالبی بود در مورد سندرم داون.
خب ما کم سعادت بودیم نتونستیم استفاده کنیم.
ادامه داره ان شاءالله.
استاد رئیس گرامی همچنان رکورد پارتیسیپنت دست روماتولوژیه. الکی نگو.
ممنون از همگی، خیلی لطف کردین.